Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast. My name is Terry Fletcher. Happy to have everybody today. Hope you are doing well with your holiday shopping and getting into the last part of December in 2018. I don't know about you, but I'm ready for 2019. 2018 has been, we call it the good, the bad, the ugly, the challenging, and I know we say that every year, but definitely had some challenges this year, but a lot of good things happened, but I'm ready to move on into the next chapter into 2019, and I hope everybody else is as well. So in last week's episode, I talked about not just payer refunds, but also about mid-level providers, NPPs, non-physician practitioners, nurse practitioners, PAs, and everything that happens with that when it comes to an NPP performing services under a physician, incident to, or even performing independent services. So I wanted to expand on that a bit this week and talk about supervision guidelines, but I'm going to back it up a little bit and just clarify some of the comments I made last week, only because I received a flood of emails and just some things that, and that people were like, oh, okay, can I do this? Can I do that? And I also wanted to comment for you out there. Just let me give you an understanding of what the CodeCast podcast is, and hopefully you'll appreciate what I'm trying to do here, because I've been on the air now for over a year. Several different entities have picked up the program. So now we're on iTunes and Spotify and YouTube and Stitcher Radio and TuneIn and you name it, we're out there. And SiriusXM Radio is looking to pick us up as well as one of their programmed sites. And so it's creating a lot of buzz, and I appreciate that, especially, being considered an authoritative reference on some of the topics. But one of the things that I just wanted to make sure you understood and really can embrace for me, I'm an independent consultant, and that's what I do. I am an educator within my coding and billing and reimbursement knowledge. I've been in the business for over 30 years. I'm a certified coder times 14, so I have 14 certifications in coding. And then also I am an auditor. Not only do I audit on the private sector, but also for Medicare. And I do a lot of other things as well. If you look at my website at terryfletcher.net, I'm sure you'll see I design waiting rooms for medical practices. We do all kinds of compliance manual creations. We go out and do on-site training, not just speaking at conferences and seminars and webinars and all that. But the reason I wanted to bring this up is that the podcast to me was a way for you to get information that you didn't have to pay for, as soon as they don't make podcasting a fee for service, but not to the point where you're being trained, where I want to give you insight to the point where if you want to expand this knowledge in an actual formal training session, then I want to invite you to go to my website and sign up for a webinar that, yes, you would have to pay for, but that comes with materials and links and information that you now can take back to your practice and utilize it as a training tool for yourself. So this is for your insight, yes, for your learning, but more as, oh, I didn't know I could do that, or, oh, now I see where she's going with that, or even something where you're like, okay, well, I was wondering about that, and now you're confident in your knowledge on something, or something that maybe I gave you some insight that you were not aware of before. But the formal training and formal coding questions and all that, those are things that you do have to pay for. And I just wanted to bring that to your attention only because I've had a flood of email, which I love everybody, my almost 30,000 listeners. And I absolutely am so happy that we've have that kind of reach right now. But when you submit a question or you give feedback on the podcast, I just want to let you know how it works, is that I'm happy to respond to a question. But anything more than that, I would ask you to go to my website and join something called the On-Demand Coding Corner, which is my unlimited question and answer service. It's a yearly fee. It's a membership. And then you also get a yearly newsletter. Then you can sign up for that under Contact Us on my website. And then that comes actually out every quarter. And then you can also get discounts on webinars and seminars and things like that. So, to keep us on the air, and because I am an independent consultant, that's how we generate our revenue. And so the CodeCast is kind of like a perk. something that I'm hoping you're enjoying listening to. You find my sense of humor to be along the line of yours. And it's just something that you can really just say, okay, give you some mindful and thoughtful, thought-provoking things in the healthcare field, hopefully some breaking news that you weren't aware of. But I'm trying not to do it in instruction format. That is more for webinars, webcasts, seminars, conferences, things like that, live seminars. This is more just for your insight. So I just want to bring that to your attention because I don't want you to, contact me and think, okay, now I can be trained through an email and all through the CodeCast. I want you to use this CodeCast, if you don't mind me kind of giving you some direction here, as something that you have in your back pocket going, you know what, let me just see if there's a topic on this is our 60th episode. So on the 60th episodes that Terry's given us that really speaks to me and things I need to know. And then when you listen to the episode, you're thinking, okay, so I need to expand on that. Where's the webinar that I can purchase and listen into and get the materials that follow that information? Otherwise, you really need to be on your own to look up some of the references I give you. So hopefully you appreciate that and understand where we're going with that. And again, we just are really happy to have you listen in and be on board with what we're doing here. So we definitely wanted to just kind of clarify some things there. Okay, so let's take a look at this week. But first, the CodeCast podcast is brought to you today by Movado Watch Company, one of the world's leading watchmakers. Movado, modern ahead of its time, Movado.com. And Simple Health Radio, discussing topics related to your health and well-being, simplehealthradio.com. Okay, so in revisiting last week, when it just comes to mid-level providers and some of the things that go along with utilizing physician extenders is what they're called formally, we have to really understand that different states are going to have different opinions and interpretations and what we call LCDs, which are local coverage determinations, on how to utilize those providers. They're not physicians, but they're utilized in a physician practice as a physician many times. And so not only is there a federal guideline, and you can find the Medicare Benefit Policy Manual guideline in Chapter 15, Section 60, and it gives all kinds of things within bold text, but I've noticed that there's still some interpretive issues that may change how you utilize your mid-levels. And again, I'm seeing some people interpret things where they're so ultra-conservative and going to the actual verbatim that they're not looking at the spirit of the rules and what you can support. And you know me, if you've ever taken a class of mine or, heard me speak anywhere, I'm not going to tell you to do anything that on appeal or if it's questioned that you can't support. I want to be, especially being a Medicare auditor, I want to make sure that you are not only above board, that you're not hanging on the edge of the cliff ready to fall over. I want you to be able to, be just saying, yeah, I'm an open book. Take a look at what we're doing here. So a couple of things that I just wanted to bring to your attention. There's a couple of opinions out there, I should say several, that may be different than my opinion, and that's okay. Everybody has their own opinion. My interpretation, though, of the rules is just a little bit different when it comes to your mid-levels. So you've got a patient that's a new patient visit, and they are being seen incident 2, meaning the physician is in clinic, the doctor started or initiated care, and now the mid-level provider is now carrying out that treatment plan. Okay, so a question came up and said, can a mid-level provider, NPP, can they change or a dose of medication? Can they order an x-ray or anything like that? And I saw that somebody had posted on one of the coding websites, they said that they can create their own plan of treatment, change the dose of medication and order an x-ray and so forth. But at the moment the NP makes an independent treatment decision, it's not under the physician's incident 2, it's under theirs. Well, that's half right. Your mid-level providers, the reason that they have the education that they do is because they can make independent decisions based on the patient's presentation. And as long as it follows the physician's overall direction and control, there's not going to be an issue when it comes to, are you following the incident 2? So what I am understanding from the Medicare manual and what my interpretation is that, let's say that you had a patient that came in and they were a hypertension patient and your physician had put them on a certain medication, but that medication wasn't working, but they still had hypertension diagnosis. They still needed medication for that. And then NP said, well, let's try this medication. They may be altering a little bit basically the treatment plan, but they're not changing it. It's not a new problem. And it really is clear in the Medicare manual that says that it would have to be a new problem for it to be an issue, and there is no new problem. And so that's where you just want to not over-analyze some of the conservative approach to that. So if the patient's saying, oh, by the way, I have this going on, and now the NP basically says, oh, okay, well, we're going to do this to treat that problem, then absolutely. That is a plan of care change. That is not something that the physician diagnosed. And so that would be part of that physician issue. And also in that policy manual, it says there may be changes in the course of treatment over time, but a physician is required to make those changes. Well, changes means that you're changing what's going on. This is not a change. This is a modification of a medicine that was already prescribed for a condition. So I'm interpreting it just a little bit, probably less conservative, but I believe that it will stand up to muster, especially since I'm auditing these records. So it's interesting just when you see this from a state level as well. So the Indiana State Medical Association came up with something, and thank you to Pam Schulman in Florida Medical Clinic. She showed me this. It says the physician ordered a drug at a certain dosage for a patient. The NPP sees a patient in a follow-up visit and determines the drug is not working. The drug and dosage are changed. Can the service be billed as an incident to service? Okay, so in Indiana, they're saying that because the NPP is now determining the plan of care, that's not an incident to requirement. But I took this to Pennsylvania and California and Texas and Washington State, and they said, oh no, the patient was still under a plan of care for the same condition, same problem, just a change in medication. That's not a change in treatment plan. And so look to your state, see what your state says on this, because in Indiana, that's what they believe. But in 5 other states I queried, they said, no, it's still the treatment plan for this patient to try and be treated and serviced under medication. Regardless what the medication is, it was just a modification. So again, I just wanted to make sure you were clear on that so that you're not thinking that you're reading the rule one way, hearing something else and thinking, okay, what do I do here? And that can happen. So you have to ask that question to your MAC carrier. Make sure that, now sometimes they don't get back to you in 90 days, but if you're at all concerned, then you want to really, get that information from that MAC carrier and see what they say about it. Because if you're not comfortable, looking at the rules from an interpretive standpoint, and you just want them to be black and white, which I don't think any coding rules are for the most part. I think otherwise your doctors wouldn't need us. It would be black and white and they just do this. I think that you need to do a little bit more due diligence. So that's what I wanted to bring to you, just to follow up on what we were talking about last week. But then I wanted to move into a topic called supervision guidelines. Now, I know what we're talking about here sounds like supervision guidelines, but it's really incident to guidelines, meaning just about established patient visits. And so when we talk about supervision, we're talking about for diagnostic tests performed in a non-hospital setting. So that would mean physician's office or independent diagnostic testing facility. And so, where does your doctor have to be when, let's say, a stress test is being performed? And where does your mid-level have to be, or what gets billed under them when your patient is having a test done and the doctor doesn't happen to be there? So this comes right from the Medicare Benefit Policy Manual. We're still in Chapter 15, but in Section 80, there's 3 levels of supervision. So there's general supervision, and that means the procedure is furnished under the physician's overall direction and control, but the physician's presence is not required during the performance of the procedure. So under general supervision, the training of the non-physician personnel who actually perform the diagnostic procedure and the maintenance of the necessary equipment and supplies, that's continued to be the responsibility of the physician. So what would follow under general? So let's just take a look at a couple things. So labs, EKGs, echoes, Holters, events, ultrasounds, things like that. Things that you can tell are not really invasive. Now you have something called direct supervision, and this is where sometimes there's a little bit of a confusion, saying, well, direct supervision, incident 2. Remember, incident 2 for mid-levels is just about office visits. direct supervision, but there's a direct supervision guideline of where the doctor has to be in clinic. But direct supervision requirements under Medicare supervision requirements is about testing. So once you have that understanding that there is a difference there, then you'll be fine. But direct supervision is in the office setting. That means the physician must be present in the office suite and immediately available to furnish assistance and direction throughout the performance of the procedure. So it doesn't mean that the physician must be present in the room when the procedure is performed. It just means that they have to be, and we call it within yelling distance. And what would be examples of direct supervision? Well, we would be looking at stress tests, so treadmills or pharmacological induced stresses, some forms of nuclear medicine, PET scans, so anything that is invasive for a physician that has to deal with that. So personal supervision, that's the next one, means a physician must be in attendance in the room during the performance of the procedure. And so, heart caths, TEs, when they're actually in the room performing the service. And just look at your Medicare fee schedule database. If it has an indicator on it, which is 1 for general, 2 for direct, or 3 for personal, you know what it is. Now, this does not apply to tests performed in hospital settings. That's different, and you want to make sure that you're understanding you're billing more interpretive codes instead of global services. And that's really the key here, is that these are global services. So you're billing the one code instead of splitting it up, technical and professional. And supervision by a non-physician practitioner, a nurse practitioner, PA, that doesn't qualify as physician supervision. That's where you can see that there's a definite difference between this and when we were talking about the office visit incident to supervision, because that the mid-level or the non-physician practitioner does qualify as a physician as long as there's a physician in clinic. So it's a little bit different. But if this performance of a specific test is within that practitioner's scope of practice, under your state statute, remember states trump the federal government, which I find kind of interesting. But when I say that, did I just say states trump the federal? Okay, sorry, I made a funny, didn't mean to make that. But what I'm talking about here is that states will basically say, okay, well, this is what we will allow. It doesn't matter what the federal government says, this is what we're saying, and you have to go by that because there's different state board of nursing based on the patient population. And so again, when the performance of a specific test is within that practitioner's scope of practice under the state statute, then they would bill this using their own Medicare provider number and also if they're credentialed with a certain commercial plan. So for example, if a nurse practitioner administers a stress test as permitted under your state statute, then a claim can be submitted to Medicare for the stress test under the mid-level provider's PIN number, even though there was not a physician present in the office suite. So you just have to know the difference there. Otherwise, there could be some issues. But pull up your supervision guideline in the discussion I gave you under the Medicare policy manual. That way you have a list. They actually give you some examples, and it can just help you when you're trying to figure out, okay, what does this fall under so that I'm accurate? So my coding question today talks about a review of systems issue that I want to talk about that happens all the time when I'm giving education. And when I explain it to the doctors and the way I'm going to explain it to you, if you're auditing your E&M medical record and you're seeing a lot of 4s and 5s, level 4s and 5s on the new patient visit, or level 5 on established, or level 3 on the hospital admissions, anything like that, or a level 5 or 4 on a consult, you're going to run into this. And this could be a huge difference in what is a complete review of systems to hit that comprehensive area versus what isn't complete, and that would downcode your code. So I just want to make sure that you're clear on what we're talking about. But first, also want to thank Trident University. Trident is a leading online university serving members of the military, veterans, and corporate. Trident.edu. Okay, so the question came in, and it came in from one of my Nebraska subscribers. When a cardiologist includes a statement like a 10-point ROS, which is a review of systems, was negative in the exam note, can we count a complete review of systems? The answer for that is no. So reporting as negative any number of systems fewer than 14 does not satisfy the abbreviated notation requirement for review of systems when you're determining the appropriate E&M service level. So a complete review of systems means that the physician reviewed all 14 systems, But according to the 95 and 97 E&M documentation guidelines, if the physician reviews and individually documents 10 plus systems with a positive or pertinent negative responses, then you are allowed to use a statement such as "and all other systems are negative." That way you can claim your review of systems. So a combination, 10 documented, all others negative, that's clearly a complete review of systems. But the confusion I'm finding lies that sometimes the coders will confuse these two facts and include that a statement such as the one, that my question person cited fulfills the complete review of system, and it doesn't, because it doesn't identify which 10 systems a physician reviewed. So also using words like non-contributory, that can confuse the issue as well, because it suggests that there were positive answers that just weren't recorded because the physician felt they weren't necessary for the presenting problem, which is wrong. So do this. Ensure that the physician documents all positive review systems and any pertinent negative review systems. If the documentation includes at least 10 systems and the surgeon or physician also states that the remaining systems are negative, then you can claim a complete review of systems. Otherwise, you have to look at all 14. Okay, so as we conclude for today, I wanted to just end with, as my usual, personal note about myself today. So I've been doing some Christmas shopping and having a lot of fun with that. And I've been finding some really fun things for people. But one of the things I found, I think, that I was most excited about was a site that actually does these bracelets, and they're called Mantra bracelets, and they're metal, and they have rose gold and silver plated and gold plated, and so they're, anybody has a really small wrist, they're great for you. Anybody that has a larger wrist, like myself, they're great for me as well. And they're just so pretty and inexpensive, but they have words on them like truth or beautiful or smart or love you more. Another one was best day ever. And I got a few for my daughter. She doesn't listen to my CodeCast because she says that it doesn't talk about anything that has to do with the E channel and the entertainment industry. So she won't hear this, I swear, our adult children. But I gave one to one of my friends, and because she was having a bad day one day, and she was just like, I just feel gross and I feel this and that. And she's quite the person. I really love this person. And KB, shout out to you. And I gave her one that just said beautiful on it, because I wanted her to look down on it. And every time she was feeling that way, just to, say, no, I am beautiful inside and out. And so hopefully you'll take a look. Again, Mantra bracelets, and I'm not sponsored by them, so this is not a plug for them. It was just a cool site, and Instagram is taunting me for those of you out there of social media and get all those ads. And I see every once in a while some things, and I love personalized stuff for other people. I actually am not big on it for myself, but I like it for other people. So how funny is that? But if you're out there shopping and you want something that gets to you really fast, that would be one thing to take a look at. Also, we're going to have an updated schedule on my website for webinars for 2019, terryfletcher.net. Make sure you're taking a look at that. We will get the NPP on the schedule for the mid-levels, and I know everybody's interested in that. Some telemedicine, telehealth to describe all of the new information. And if you just need a rundown of what's happening with Medicare, I give you a lot of tidbits here and there, but we have a pretty big webinar coming up on that, and then some specialty classes. So make sure you take a look. And I hope that's what we're going to wrap it up with today, everybody. So have a great rest of your week and make it a great day. And thanks again for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.